Um, Hello, everybody. My name is George Perendia. I'm grateful and it's honored to actually be here and present my work. I'm really thankful to John and Ayla for inviting me and Henry for emailing invitations. I need to emphasize, obviously, few things. First of all, I'm not health or biomedical expert and specialist by training. So I cannot make any claims in that area, and I'm not trying to make any claims in that area. I'm really just looking at the problems of health and ethics, of the economics of the both, or the economics of the health, for example, or health economics area, and its research, which is something that I kind of got involved more recently. And after finishing my PhD, which actually was in financial economics. But the COVID made obviously some impact on everything. And I have been now paying some more attention to health economics too, and its research. I changed slightly the title to some fragments because overview is, I think it's a bit overwhelming and over-encompassing title. And I'm trying to actually only bring some aspects because it's a huge subject, and especially in context of COVID-19. And I can't possibly handle all aspects and provide anything like a overall overview in this kind of time or this kind of paper. So that requires much more work. So I'll focusing just on some fragments of the issues. This is kind of this interdisciplinary approach, as I mentioned, from points of economics, philosophy, and generally scientific research, something I've been also looking into more recently, much more, and the epistemology of scientific research too. In general, I've been kind of involved more in these two aspects of philosophy, ethics, and epistemology more recently. First of all, I just want to give a brief introduction, ethics versus morals. Philosophy doesn't usually make huge distinction between the two terms being one from Greek origin, the other Latin, effectively, at least etymologically meaning very similar things, but some people are trying to make distinction, and whilst morals tend to be more deeply embedded in the culture and the upbringing, ethics tend to be more kind of positive rules and agreements-based rules of behavior. And so one can also argue further where they come from, but I will not get into this problem of, shall I say, metaphysics. However, I said ethics is probably more related to what we usually refer to as a social contract in general. Just on the other side, for example, Paul Ricoeur, I'm not sure exactly how to pronounce his name, took slightly the opposite distance, but he was trying to explain this difference in slightly different manner. But common approach is what I explained before, and I would like to stick to that for the moment because it's more commonly, at least as I understand, used. But correct me if I'm wrong, please, or maybe have some different positions on that. In terms of medical ethics or medicine and ethics, I mentioned basically, sorry, I didn't mention, but I will look into this problem from focusing mainly from kind of two relatively opposing points of view, contemporary, one being more libertarian and based on also turned around roles, the other being kind of more utilitarian in terms of the consequential utilitarianism rather than original classic one. This consequential is often being kind of part of the policy of the public services. Modern classics haven't been involved in writing in getting involved into healthcare issues, and not even Rawls himself didn't go much into detail, even though he was a mid 20th century philosopher, or even mid to late. And possibly because where he worked in the States is a very ticklish subject. As we know, it still is, and so and there are still different views, and particularly people who don't really want to get involved, who don't want such a help, and for a variety of reasons, sometimes spiritual, sometimes simply a freedom or libertarian position that prevents them to actually, or doesn't give them reasoning for such a service, etc., etc. I'm not actually even going to get in the detail of discussion. I'm just kind of really just briefly just to kind of skate through that. So it also positions health as a natural primary good, similar in fact as to Locke, but they don't want to introduce it into a social contract and leave it out of social contract and out of social context. For that reason, for the reasons I mentioned, probably he didn't want to get involved down that line, going down that line. I can argue maybe that maybe some actually in my talk, I'm actually also presenting a model of the health as a kind of natural endowment, or form. I'm making it more kind of aligned to what actually natural property was in Lockean sense, for example, which became part of the social contract, etc. So, so in that sense, I'm also taking a stance that there may be some also reasoning for social protection of the health. Oops, sorry. No, I'm going wrong direction. Yes, so the natural left vulnerable, for example, are usually from Rawlsian position. Even one can argue that if he wants to give them egalitarian start, as in a manner he was doing for even asking for education to be a common starting point, and give some kind of at least chance, equality of chance, then one can also argue there may be some reasoning for even evening or helping those that actually came naturally born with some problems or developed them in early age and stage. And on the other hand, there's another aspect which is like because Rawls was saying that the health is not socially conditioned, but some parts of the health, like particularly working in mines and plants and being exposed to pollution, which is a result of the social action, often can have a negative effect. And hence there's another argument for society getting involved in social protection of the health, and taking responsibility, at least some forms. I'll go to 3. So in this position, I'm not arguing for the full featured health protection for all possible alignments. I'm just talking those that have been affecting more people in a line that would be protection basically of natural, one-way natural endowment as it is given by natural, shall I say, the contact from the natural state, social contact coming from the natural state, and this natural, as much as the property and other natural, shall I say, law rights, the health as endowment should be treated in a similar manner as the property rights, if that is. This is, I'm just talking, this is an academic discussion. I'm just taking this position for the moment for discussion point of view. The so it, as I mentioned, also some other aspects of the disease or problems that occur from the social context, working social context, may also need to be covered by this protection too. Right, this is some kind of links, then references. So basically, so I'm also now presenting a different approach to basically health, or should I say well-being as endowment, as a form of of property in a way, which may require protection in the same manner as, for example, your right for the physical protection against violence, or protection of your property rights may need to be put in place in terms of healthcare. Here I'm just also depicting something that is to economists is quite relatively well known, utility curve. Usually with that variety of these utility curves, so utility models that can be used to model one's utility or from some, shall I say, ownership, from, let's say, owning goods, owning private property, etc. That utility, personal utility, has this kind of diminishing upward curved diminishing trend, because the more we have, usually people, at least it's been perceived, have a less desire and less utility from more and more, shall I say, dollars in the bank, or houses, the holiday cottages they may have around, scattered around, cars, etc. So this utility curve, I think, can also be applied to health and well-being. And those that are on the lower end of it, poor health, any kind of, should I say, linear increase in their health can actually increase their well-being and their sense of well-being much more. For example, if you take it here, much more for the same step of, let's say, 40 points. I'm just looking for points. This is something also predicting something different, but let's just then, for example, somebody who gets I don't know, hundreds of points at this point in his, should I say, well-being, health, well-being. So this is actually, I'll come back to this probably later. Why I have these numbers here? They, in this context, they just depict expected longevity, the life expectancy, and I have put here in months. So this is about 40 years of life expectancy, and I said, this logarithm curve is just a one possible model. There are different slight variations to the curve, etc. But we will not get into, for this discussion, into these details. Now, okay, so now coming back to COVID, this is part of the introduction, my position on the morals and health. In terms of COVID, the ethics is being also applied as applied ethics, has kind of, there's a lot to be written and a lot to be discussed about it. And of course, in a conditions of quick decision making, in incomplete information, a lot of decisions were made with a very high level, shall I say, of uncertainty of what the outcome will be. Partially, this is something that usually is required in urgent situations, in situations of, states of emergencies, which we are actually, or most of the countries have been in some form of state of emergency, whether it's called health emergency or different titles. But it required a quick decision making and quick implementations. Not far, some people compared with war. It can be compared in many ways, partially because of obviously there were victims, civilian victims, as well as the people who died in the line of the duty, etc., etc. But obviously some other people are not agreeing with that, and there are other consequences of even taking that position, because, for example, for insurance purposes. Okay, so there are different reasons. For different reasons, people, there were very different positions on that, whether it was almost like a war or not. I won't go to that now. It's just saying, I'm just stating here some known facts about different countries taking different positions, at least at the beginning, like Sweden taking very liberal and backseat position, as opposed to some other more, shall I say, other EU countries around the heart of the EU taking slightly different approach, and some other countries kind of jumping in between the two. I don't want details. I'm just want to mention that one point I want to raise is that often people called upon scientists, and I'll explain why I'm coming to that. I'm just giving this kind of introduction picture, but why the people actually calling, the politicians have been calling and say, we follow the science, we follow, advise the scientists, etc., and giving sometimes scientists decision-making role. On the other hand, scientists have been often saying, well, we are not in decision-making role, and I'll come back to that why in more detail, but in part, scientists at least saw themselves as somebody who can give informed view on the outcomes, effects of particular actions, and maybe finding a different forms of optimization depending on the optimization criteria. That doesn't necessarily mean this is the best decision, because best decision depends on obviously optimization criteria, and who is supposed to give criteria. This is effectively somebody who is in a decision making role, and this applies not only for this occasion, this applies even for economics, and that's something we can discuss out of this discussion, out of this kind of outside of this discussion now. So, but this is a one more conflict, because I think there was some kind of a level of responsibility gap or misunderstanding of who actually is taking decisions, or who should be taking decisions, and who should be just giving advice on decisions to be made by people who actually are responsible for making decisions. Now, yeah, so basically I just want to give an overall assessment of the different positions of these countries, and effectively mention that countries have been taking care of more vulnerable ones, and are by doing that affecting the or shall I say, overall well-being and welfare of some others, have been acting more kind of utilitarian manner, and less in a kind of roles distributive justice manner. So right, so this is actually some reason I'm not mentioning in a text, but I think I'm mentioning in references. There is actually also very good Canadian philosopher who wrote back in the 80s and claiming that almost behind every research, scientific research, there is a certain element of ideology, and outcome of the research is often conditioned by ideology and moral positions. We said before, moral positions are something that is very deeply embedded in a heart, in a mind, like a heart in a metaphorical sense, but not just metaphorical, because some people say that heart has a part of the logical decision making. So it is something that is deeply embedded in our minds and, shall I say, neural networks throughout early stage of our upbringing, education, and it's often difficult to overcome when, for example, scientists ask, okay, what is the best solution? Well, the best solution is to let everybody who should die, and that's the best solution, because maybe he has been brought up in that manner of thinking, and which can bias his priors in his posterior decision-making, Bayesian posterior decision-making, which he's taking throughout his scientific research, but the prior, it may be even subconscious or semi-conscious or subliminal. So that's the reason I'm arguing it's not necessarily scientists who should be making decisions. They should be giving advice on outcomes, etc., as a group. But those that actually have been chosen to make decisions probably should be. That's what. So basically, I'm saying I've been involved in many aspects of scientific research. In fact, because I was working for Psycholinguistic Research Center, I was looking for Archaeological Research Center, I was working also for economics research centers, and to name a few. And each time I was also quite deeply involved in trying to understand more about these sciences and how they work. But I have to say, all the time I've been finding traces of ideological or political bias in decision making, etc., etc. This is just my own experience, but as I said, there is I'll come back to the name of the other philosopher later, who also wrote his paper. It's available on the internet in French. For example, I'll just give you one quick example in terms of archaeology. We talk about archaeology as a kind of positive science, almost exact science, but often archaeologists have been in past and more recently involved in finding arguments for pro or contra some social or entity or ethnic group having a historical root in a particular area, which can affect legitimacy of the existence there, etc., etc. So all these kind of decisions can have a very strong political implications, and sometimes decisions and of these scientists have been also biased in making recommendations in that sense too. So I can only say that. I don't want to go into details now, particular details, but this is just one of the examples. Another aspect is that I would like to mention, we also, at least epistemologically, talk about the human kind of reasoning of the causes, etc., as a finding a cause, well, not finding a cause, basically in human sense, and so-called primitive sciences and primitive medicine, for example, what we call primitive medicine, which modern medicine is coming back more and more to. This is what, for example, Lévi-Strauss, a French anthropologist, have been writing a lot about it, about the so-called primitive mind and science, sorry, minds, consciousness and primitive science. But primitive science is often the shaman science, what you call based on voodoo. It's not. It's often based on long-standing empirical, generations-long empirical research. Not very systematic research, but still research, experience, finding that some treatments, exercises, some herbs may help in some situations, in some alignments, in some illnesses that occur in a group. And yes, they may have been performing also a ritual around treatment and bringing what they model of the causes, where the causes, the spirits and ghosts and that are actually affecting human being, etc., but often the outcome was positive because the herb did its work, at least the herb, if nothing else. And yes, the person was often healed because of the long empirical research and identifying a particular treatment. In that sense, almost in the human sense, you can say even this so-called primitive science, medicine, was not so primitive because, yes, it used a different causality model, but causality models are anyway part of the belief, if you take the human's position, the part of the belief, etc. So, because I'm just bringing also some aspects of the medical ethics and medical research, but this is another. Okay, so I don't want to go to this now because obviously the body snatching, that was part of some practices in earlier centuries for research, including artists like Leonardo da Vinci also had to get involved in this kind of, should I say, body smuggling to be able to analyze anatomy and do his paintings and drawings so precisely as he did. Testing, another moral aspect of the ethics in medical research. Who should be test medicines on and treatments on, and who are the humans, or who are the cousins? Because we have that, it has been recently identified, even some Canadian scientists are talking about it, that animals also commit suicide in this test because they've been exposed to such harsh conditions, they cannot sustain the pain or the condition they've been exposed to. So obviously it's saying that, oh, animals don't feel, it's not the case, but it goes quite low down the line. So I don't want to go to obviously the cases of extreme exposure of concentration camps and using different. I'm just kind of going through this, questioning what. It's a big question: who and how the people who are tested should be selected and how they should be awarded in return for the risk that they're being exposed. Now, I'm just coming to the one of the main points in modern health economics, the measure of the treatment efficiency. Okay, we have done tests, etc., and we can identify maybe what they say. It's something called quality, and that is effectively what they say is a number of full well-being quality, full quality life adjusted years that a treatment brings to a person, or at least an average, depending on the conditions, the state of the health, etc. But some treatment can obviously bring something to different people, but there's some average with the variations, with variance, etc. And it has become one of the most commonly used measures. It's been introduced basically back in the 60s and 70s. And a similar measure is QALE, which is basically says quality of the life expectancy, or quality years of the life expectancy. I think, as I understand, quality with Y is used mainly in a short term for a short measurements. Expectancy is for longer periods where the uncertainty is higher, with lower certainty, I should say, of the estimate. This is just a little description of that. For example, what would be effect of, should I say, one's life and quality of the life. This is a quality and the length is achieving. So quality gained from treatment. This kind of sum or integral of these values would be giving that final quality measurement, as opposed to, for example, what is without treatment. And this comes from initially some predecessor works that earlier I mentioned. There was actually an organization, American Health Organization, which came with this overall measurement of the efficiency of the health, where priority is basically measured in terms of incidence of death to the disease, product number there, vulnerability, effectively vulnerability of the disease to the treatment, which is effectively what is the efficiency of the treatment, and that can possibly be a similar measure to the quality I mentioned before, against the cost. Now the science, medical economics tends to use a slightly opposite, slightly different measure, which is like the cost efficiency ratio, which takes cost per quality, or should I say cost per year of attained by the treatment. Or York University has also introduced so-called incremental one, which is basically based on the deltas of the two between maybe two treatments, and simply, obviously, the lower cost, lower incremental cost of a treatment per quality gives precedence to that particular treatment over the one that has a higher cost per quality of attained life. So no much brainer, should I say, just going to say, this actually works almost in a similar manner as a capital investment. We invested so much money, and this is a return we have in qualities. Now, quality is not only used in economical assessment against the cost for the investment in research or investment in capital investment for the hospital and treatments, but it's also is on its own without the cost side so much is used in everyday decision making by doctors and nurses, etc., in terms of a triage nurse had to decide who to put onto single outstanding free ICU bed, which is the resource. So how many QALYs can we achieve per bed in this case? That would be kind of rationing behind that. Or doctor may have to decide, obviously in COVID situation in Italy, who to put on the remaining single available inhalator, the elderly person who has maybe a couple of years of life anyway, or younger person who can be saved and achieve higher quality in the sense of the expectancy, life expectancy after the treatment, after successful treatment, etc. So these are decisions that have been made on a daily basis by doctors in this, shall I say, war situation, and they are done in a different similar situations elsewhere. And this just give a briefly a numerical example. It's not very, I don't want to bother you too much, but this is not very complicated, but it's a very simplified one. But anyway, I'm just saying life expectancy, I say, old smoker patients with life expectancy of only 5 years, or young, healthier patient with a much longer life expectancy. They both would be living maybe just 1 year if they don't get heart operation. So we're talking about single resource again. Single resource is the operation, which needs to be performed urgently. Who to put first, and hence this is again something that surgeons, or as I said, sometimes maybe even AI system in a hospital has to make decisions about, which of course it's all seems so far quite straightforward, except there are some problems. Problems with the quality, I identified, and some other people have identified too. Basically, one of the main problem with the quality, and as people who are also involved in investment, etc., we recognize its absolute return. And although we're talking about return on investment in a monetary sense, there's another investment, and this is an investment in a quality of the life of the individual. So we're talking about two different investments gains in so this is what I'm trying to bring also just to a problem with this particular I think I'm running out of time, so you know how much time you still have, because John, how much time you're giving me? So I can't hear you.
Yeah, I unmuted myself again. You're screwing up the recording now, but we'll edit that out. As long as you like. How much time do you need?
I'm sorry about that. Sorry.
Yeah.
Okay, right. So so how does it actually reflect? It reflects, for example, a similar example, but we have a person who would have had expectancy much longer anyway, and operation brings only small improvement later on. So as we discussed before, this kind of discounting curve or diminishing return on the well-being has effect that sense that even, should I say, while we can see that total quality of, shall I say, gain of one, this could have been a bit longer, because usually longer people with long expectancy have also better post action quail gain as well. In that sense, a person, again, healthy person would been given precedence, even though one can argue that in relative gain, it is the other person who has a less starting, less poor in that sense, in poorer health and poorer, shall I say, welfare in terms of health, would gain more even if they both are gaining 5 years or similar number of years. If the difference is not a big, that person may actually be gaining more in their personal gain of the well-being, rather than the person who may attain 5 years on top of their 30 years of life later on. So this is a problem, but that sometimes the system would give a precedence to this, sorry, advantage to the person who actually has a longer quality after that, but not necessarily relative gain in well-being coming from that discounting curve. The other problem is that, and this is actually quite, this hasn't been covered elsewhere, as I understand, giving one person who has a longer life now a treatment would actually increase the longevity expectation for this kind of group of the people. And that can lead to actually exponential differentiation between life expectancy of the two groups, because that group that had a slightly higher expectancy would be given more and more treatments, which will be exponentially increasing their life expectancy, as opposed to, or as a difference to the other one. This is actually exponential curve, but it's very slow increasing, because I'm just giving a small value. But this gives you, for example, the values don't appear to be very significant, but obviously if somebody can say that over 100 years, increasing the life expectancy from, let's say, 75 to 83 years may not be a great deal, but it is socially probably problematic if you know that, in fact, it is a part of the result of discrimination that between the two groups, and one is being given exponentially more and more longevity, shall I say, gain, wealth in terms of the health measurements. So I'm just summarizing here this. What I said before. And one can argue, okay, maybe we should really have more paying attention to the relative one, and taking actually that as a part of the decision, at least, or as the main decision making, rather than absolute value. Because, for example, if investing money, you can say, okay, this investment gives me $100 dividend, and this one only 5. So I'll go for 101, but the 101 will cost you 10,000, and the 5 will cost you maybe 500. So in that sense, you actually be gaining more on the smaller investment, smaller gain, because relative return is your higher. This is just comparison with that kind of way of thinking. So those who are coming from that bit way of thinking. So should a social service, or should I say health service, be more involved in that? this solution said may be acceptable or may not be, depending on the criteria for the consequential utilitarian. But from the Rawlsian point of view, it's probably unlikely to be accepted from the liberal Rawlsian, because, for example, as Amartya Sen, in one of his articles, claim the main difference between consequential utilitarian and approach and the Rawls notion is that being just is that Rawls require the person who each giving in has some kind of return, or at least, overall society may have, including that person, or at least that person has some gain from this loss. It's almost like a trading, as I understand, trade-off that Rawls requires, at least in his system of thinking, that to be justified, this kind of giving in. So I can say maybe this person that is being given to maybe a very significant person for society, contributing, writer, I don't know, some intellectuals, some scientists, Stephen Hawking, etc., etc. So I'm not going into details, but this is something that if this person may have been giving something to society, this can be justified easy, of course, and this is what happens usually in practice too. Or maybe important just for this person who is at loss, in that sense, who is. Now, just one, also, quality has implications, can have different measures depending on the window. If you say, I'm taking psychotherapy and versus opioids, opioids are cheap, let's give them opioids, but opioids may need to be taken over 10, 20 years and increasingly more and more, as opposed to therapy, which may last a couple of a year or two and resolve the problem. So if you take your window of measurement very short, obviously opioids may provide a high quality, but if you take it longer, obviously depending on your investment window, yes, maybe therapy can prevail. Just modern phenomena, not so modern, but we've been facing, and not more term, agnotology is a term now being used for, especially now in terms of COVID, but there's a lot of almost commercial investment going into providing alternative science, which will contradict the mainstream science, at least mainstream, but academic mainstream science, independent one. And that was the case, for example, with tobacco research, which was obviously contradicted many times, tobacco cancerogenic factor. But both pesticides. So another problem of, should I say, problem for economics, business, and health, how they can relate. I'm just kind of raising some questions. I'm not giving answers to this one, but I'm just raising some standard questions, or at least not so standard because they're relatively. I don't think I want to go into this geopolitics of the COVID, etc., the vaccine, etc. So I think this is basically it. What I wanted to say for today. These are some references. Oops, why is this coming back? Always returning. And yes, thank you for listening. And please, if you have any questions or suggestions, we can maybe start discussion.
Well, thanks very much, George, and we'll move on to the discussion now. I'm going to stop the recording now.